Hello and welcome to this session. This is evidence-based practice and is it a possibility in a resource-limited setting? I'm mainly going to share from our personal experience at the United Mission Hospital in Tansen, Palpa in Nepal. And hopefully there will be things in this that you find useful. The things that we'll be covering today, I want to talk about what is evidence-based medicine and why do we use it? Also, I want to talk about the history of our hospital and then the background of the development of our Tansen clinical guidelines. And then finally, the current status of using point of care access to evidence-based resources, some of the challenges and the lessons that we've learned. And then we'll have some time for question and answer at the end. So what is evidence-based medicine and how did it get started? Well, it's in the simplest form, it's applying the evidence that is known about diseases and treatments to the particular patient that is in front of us. Surprisingly, this is a fairly recent development. A lot of medical practices over the centuries were just based on personal experiences and anecdotes, or even worse, they were based on worldview and philosophical positions and had nothing to do with observations. Some of the early pioneers in raising awareness of the need for research were Jean-Baptiste van Helmont, who talked about doing a study with bloodletting. He said, let's have 100 people released from the poorhouses that you treat with bloodletting and that I treat without bloodletting, and let's compare the results. And nobody took up his challenge, but he basically presented the understanding that a controlled trial of treatment would give evidence of the effectiveness of treatment that then would help guide us in our treatment. A well-known study by James Lind in 1753, when the British Navy was suffering that a lot of the sailors were developing scurvy during their travels in the seas. He divided the sailors into groups and fed them different food supplements. And he found that the groups receiving oranges and lemons did not suffer scurvy as much as the other groups. So there was some awareness that was starting. However, the continued reliance on expert opinion and personal experiences over evidence continued well into the 20th century. And several people began advocating for evidence-based research and evidence-based treatment protocols. Evidence-based medicine was gradually accepted into the policies and guidelines by different societies, actually not until the 1980s, which is quite surprising. So we're talking about integrating the evidence of treatment into our treatment plans. Something that happened about the same time is the great proliferation of medical publications and randomized controlled studies. It's hard to say what was cause and what was effect. Was it because we became more aware of the need for evidence that more research was done and evidence was presented? Or was it because evidence was presented that then the medical community became more aware of the need for this to become part of our practices? But you can see on the graph how from the 1940 to 2020, the growth of medical literature was exponential. So there's 4 components that you can identify in evidence-based medicine, and I'm going to go over each of these 4 components stepwise. First is to formulate the clinical question. Then you find the best available evidence and assess the validity of that evidence in addressing the clinical question you formulated, including the internal and external validity. And finally, you apply the evidence in practice along with clinical expertise and patient preferences. So the first step is formulating the clinical question. Of course, the question we really want to ask is, what should I do with my patient, this person who's in front of me right now? But that's a question you will not find any evidence for. You have to find evidence that's relevant and apply it to your patient. So the evidence we're looking for, we need to formulate a question that pertains to a relevant patient population. You want to find studies that have been done in a population that's similar to the patient you're treating now. The second part of the question is what intervention is being considered. If you're not clear on what you're evaluating or what your option is that you want to assess, you will not find an answer. The third component is that you need to have a comparison, the control group or an alternative treatment that you're comparing it to, or an alternative patient population that you're comparing your population to. And the final component is what is the outcome that you're interested in. So, for example, you might say, what's the best treatment for diabetes? Well, that's a very hard question to get a reasonable evidence-based answer for. And I've given a sample question that contains these four components. Is metformin more effective than sulfonylureas in reducing morbidity and mortality in obese type 2 diabetics? This has a defined patient population. It tells you exactly what intervention is being considered and what the comparison intervention is and what is the outcome that you're looking at. So this would be a very valid and useful clinical question for you to use in your evidence-based medicine database search. Now, just talking a little bit about outcomes, we do need to be careful of what outcome we're looking at. Many studies use a composite outcome. For example, for studies on coronary artery disease, often the composite outcome is the combined total of deaths, cardiac events, or revascularization procedures. Unfortunately, when they were comparing coronary artery bypass grafting to angioplasty and stenting, with the composite outcome, the difference between the two groups was not so significant, in spite of the fact that mortality is higher in the group that had the bypass grafting, but the revascularization was much more common in the angioplasty and stenting group. So when you combined the outcomes, the result was not significant, and it was only after the separate outcome was looked at that they were able to determine the different results from the two interventions. Also, you need to be aware of soft outcomes. This is as opposed to hard outcomes such as death, hospital admission, or disability. Soft outcomes would be things like quality of life or level of pain. These are things that you need to have a measurement tool for that's been validated so that you can objectively assess the outcome of this clinical question. And the third outcome to be careful of is surrogate outcomes. We want to know, is the patient going to get better, or is the patient not going to die or not? Whereas a lot of studies are done on things like lab results. Does the HbA1c improve more? Or does the cholesterol level go down more? And these are not actually the things we want to know. These are the surrogate outcomes for the things we really want to know. So when you're looking at a clinical question, assess your outcomes carefully. So after you've formed the clinical question, the second step is to look for the best available evidence. And there are multiple data sources and places that you can go to look for these evidences that we are going to assess and apply to our patient. Most of you are probably familiar with quite a few of these. There are qualities that are desirable in a reference source, and some of these are listed here. It's useful if you can rapidly access the information. And this is because we want to use the evidence-based medicine information at the bedside while we're actually encountering the patient and making the decision. So if it's not within minutes, it's certainly useful to research and study and present in journals, but it's not going to be useful at the actual clinical encounter. You want to look for resources that will address specific clinical questions. It needs to be evidence-based, based on current research information. It should be portable, so accessing on your smartphone or electronic device is desirable, and it should be user-friendly. When we're looking at the evidence, there are different quality of evidence that we can look at. We can look at primary or original research. We can look at systematic reviews, such as meta-analyses, and we can look at summaries and guidelines. These are going to give different strengths of evidence for us to assess and look at. You want to make sure that the information you're looking at is addressing the question appropriately. For example, in primary research, if you're looking at the result of an intervention, the best method in the research should be a randomized controlled trial, where you have a group that receives the intervention you're interested in and a group that receives the alternative intervention or the control group. This is better than looking at retrospective cohorts and case studies where you won't actually get a controlled outcome that that will tell you what happened to the patients that were treated with your intervention that you're interested in. Whereas if you're looking at the effects of risk factors on outcomes, the best study would be a cohort observation group where you follow patient groups with and without the risk factor over time. And this would be more likely to detect a significant difference than a case control study where you get patients who do and don't have the outcome and then retrospectively see who had those risk factors. That makes it much harder to prove a causality as the of that risk factor. When you're looking at systemic reviews, this is more than just literature review, but it needs to be systematic. So the strength of the systematic review depends a lot on how the research was found, how they discovered the studies they were going to review. And this is important because of something known as publication bias. If you do 10 studies on a certain intervention and only half of the time the intervention showed an effective outcome, a significant difference in outcome, probably the studies that showed that significant outcome are much more likely to get published than the studies that didn't show the outcome. So you may end up with published literature showing several studies that look like some intervention was effective. But if you actually search for unpublished studies, there may be an equal number of studies that showed that it was not effective. So the method that the systematic review uses to search for these research papers is very important. Of course, meta-analysis is a way for getting much more powerful statistical results than you can in a single study. So it's been used very commonly now in finding evidence-based recommendations. The final level and the highest level is the summaries and guidelines. And these are things that societies or panels would publish, which give recommendations or guidelines. And hopefully they are powerful because they are based on systematic reviews. For them to be trustworthy, you want to look and see if these summaries and guidelines are relying on systematic reviews or not. Or it may just be a panel of experts that sit down and say what their opinion is, in which case the guideline would not have much value. You also want to see if they give a grade to the quality of the evidence and to the strength of the recommendation. And most peer research journals now have a grading system of the evidence that they use to tell you how strong the evidence is and how strong the recommendation is. And finally, you should look for guidelines and summaries that show an explicit connection between the evidence and the recommendation that's being made. So you've formed the question and you've looked for the evidence, and now we want to assess the validity of the evidence that you found. And this is looking at both the internal validity and the external validity. In looking at the internal validity, we're primarily looking at the biases that might be in this publication. And this is not a exhaustive list by any means, but they may do studies that were not blinded or only partially blinded. They may be excluding subjects that were lost to follow-up or refused to participate. There may be a publication bias, like I previously mentioned. So there are many things that can make the validity of the study less. The other thing to look at is the p-value. And this is the possibility that something that actually is not true may look like it is true just by random chance. If you flip a coin, there is a 50% chance that the coin will land face up. But if you do it enough times, eventually you will have 10 times in a row that the coin lands face up. Very uncommon, but it can happen. So you need to see how likely is it that they're going to get their result just as a matter of chance to see if the evidence is actually valid or not. The other kind of validity we need to look at is the external validity. And this is primarily the problem that the group they studied was different from the patient you are trying to answer the question for. You need to look at where the study was done. Was it in a referral center or a specialized center where they're likely to get a very select group of people that would have different results or different outcomes from the treatment you're considering? Or maybe it is just an ethnic or economic difference that makes the patients have different outcomes. Or they may be in a place where there are different resources available to manage complications, so that would also change the outcome of their patient panel. So you need to compare your patient with the patients that they actually studied. And now, just as a footnote, many studies have subgroup analyses that they do. This would be where they study all patients with COPD for a certain intervention, but then they might select out people who have a history of asbestos exposure or a history of tuberculosis in the past to see if that subgroup had a different result. This is something that you need to be careful about, because whenever you start selecting groups out of the main cohort, there's more likely to be that one or more of those groups, just by random chance, will have a statistically significant result. So you end up with a biased and invalid result, even though they look like they are statistically proving it. So be careful of these subgroup analyses as a way to apply to your own particular patient. So now that we've decided the evidence is valid, we will apply it to our patient. And there are two different settings in which we might apply this evidence. One is in population-based policies, and the other is for our individual patient. Many societies and governments, and especially insurance programs now, they are having to decide, what are we going to pay for and what are we going to justify doing? And for these, they need much stronger evidence that the treatment that's being done is effective. The second category or situation is when we're treating an individual patient. And for these, we get the general principles from the evidence-based medicine, but there's still flexibility in applying it to your individual situation. And I want to show a graphic illustration of this. The scientific evidence that we get from our databases and research will give us a relevant scientific evidence, but that is not all there is to evidence-based medicine. We also are using our clinical judgment. So our personal experience is actually valid from a separate vantage point than just the evidence that we find in the literature. And the third perspective we need to consider is the patient's values, which may be in their cultural context, or it may be their individual values. And these also will guide our evidence-based treatment. So I put in a quotation here: evidence-based medicine is the care of patients using the best available research evidence to guide clinical decision-making. The focus is upon applying the results of research involving patients and important clinical outcomes, such as death and symptoms. Evidence-based medicine is meant to complement, but not replace, clinical judgment tailored to the individual patients. Similarly, evidence-based medicine and the delivery of culturally, socially, and individually sensitive, effective care are complementary, not contradictory. So I'm going to move on to the second section of my talk now. I'm going to talk a little bit about the history of our hospital. And many of you may even know the history of the country of Nepal. that it was a closed country until about 1950, when the first foreign people were allowed into the country. Karl and Betty Ann Friedrichs were founders of our hospital, but they first came into Nepal to do bird observation in 1951. And on these trips, they treated patients. They finally were given permission to found hospitals in Nepal in 1954, one in the Kathmandu Valley and one here in Tansen. They started work in Tansen in a rented building and started building on the site where we currently have our facilities at 1959. After several decades of expansion, we now have 169 beds, 400 plus staff, and 40 to 45 physicians, including our junior doctors in training. And we're a referral center for the surrounding districts, especially for certain cares that we have expertise in. We do have a recurrent budget of salaries and consumable expenses that are mostly covered by patient fees. Overseas funding is used for our capital projects, which are on a separate budget, and for giving free care to the poor. Of course, during the pandemic now, this has become quite challenging. The motto of the hospital is that we serve and Jesus heals, and our hospital continues to emphasize not just patient care, but training. And we have a weekly doctor's tutorial session on Wednesdays when we close the outpatient department and the routine operations so that we can do organized teaching in addition to the bedside teaching and clinical teaching that's happening every day. So as a part of our teaching, we have developed the Tansen clinical guidelines. The history of this is more or less by accident, I guess. Initially, the doctors who came out started doing the best they could with very limited resources, and when new doctors arrived, they gave verbal help to orientate the new doctors on how we did things here. So this was really not very much evidence-based at all, but based on personal experiences of our founding doctors. During the 70s and 80s, these verbal hints started to become typed pages that were being passed around. And we also started getting some Nepali doctors who had completed their training and came to work with us after finishing their internship, and some of them with postgraduate qualifications too. In the 1990s, the first version of printed guidelines in booklet form was put together by Dr. Max Watson. And this was like a pocket book. Of course, this was before internet and smartphones, so the printed format was the way we all had access to the information there. And this was quite a simple thing that we could carry around in our lab coat pocket, quite small. But as the years went on, more and more details and more topics were added, so that by 2012, it was getting to be quite a big booklet when it was published, the third edition. Dr. Sunil John was the editor for that. And it was also edited so that it was accessible by online. After Dr. Sunil John left, I took over as the training coordinator and have since then been working on continuous updated versions being released online, as well as a printed version that we've tried to release. I put the link up here on this page for the most recent online update version. So how do we develop the chapters in the Tansen clinical guidelines? Well, a lot of the time it's when a need is identified, when we are doing bedside teaching or patient care and we find that the junior doctor is lacking in knowledge or skill. Of course, we try to instruct them there. We may refer them to a resource, and one of the resources we look at is the Tansen clinical guidelines. And if we find that there is no chapter on the subject that needs to be covered, or if the subject is out of date in the Tansen clinical guidelines, we would also suggest that that be rewritten. We also sometimes bring the matter to the Wednesday tutorial teaching sessions where we might find that the chapter needs to be written during that session. An author for the chapter is identified. Usually the person presenting the Wednesday session is the one who would author the chapter. And this person is asked to rewrite or write a chapter on the subject. Some chapters are quite succinct and may just be 1 or 2 paragraphs. Others are quite extensive, going on for 8 or 10 pages in our guideline book. The department head of the concerned disease is usually consulted and advises the chapter author on the content of the chapter. And then this is forwarded to myself for editing and formatting to put it into the online version. Each chapter, as it's done, is uploaded continually. And then every 6 months, the link is shared with all our doctors for access on their smartphones and to have it portably accessible to them. We've said that we want to put out a printed version every 5 years or so, whereas in fact it happens when we finally feel that the old version is totally useless. And so we were using the 2012 edition until this year when we were able to print another edition of the Tansen Clinical Guidelines. So how are we using evidence-based resources in our hospital? We try to use it at the bedside as appropriate, and this is what we should all be doing. It's good to have a lot of knowledge in our heads, but we forget things, we get confused, or we may be biased in the things that we remember based on our most recent experiences. So it is good to have access at the time we're making decision at the bedside, in the clinic, in the operating room, to this evidence-based medicine. We have Tansen clinical guidelines on our phones, and many other resources can also be uploaded onto our phones for access at the point of care. There's also additional materials that we can access which are not convenient at the bedside, but are useful for preparing teaching materials or for developing our Tansen clinical guidelines. An example of this is the Hinari database, which is maintained by the WHO. It is access to all the literature published in all languages around the world. And for those of us working in developing countries, we can get approval to access this at no charge. The third evidence-based medicine that we use in Tansen is the guidelines by the national and various societies, where they have protocols and routines that are suggested for use in Nepal. And some of these we access directly, some of them we summarize and put into our Tansen clinical guidelines. So this is probably the main slide I want to spend time on. What has been the challenges in using the evidence-based medicine in our hospital? I've written 6 here, and I'm sure there's more that you can think of when you think of your situation too. First one is just the time limitations to create our own guidelines. Everything is updating rapidly with all the research and information that's coming out and recommendations that are changing, new diseases, new treatment options, and it's very difficult to keep our Tansen clinical guidelines reasonably updated so that they're useful. And we are not like the big societies that have dozens of people on the panel writing protocols and editing and reviewing and publishing them. So we find that this is quite a challenge, especially for me as the editor and the one who tries to get people to write and who often writes the chapters myself. So that leads to the second difficulty is it's hard to get people to write protocols. Most of us didn't become doctors to sit in front of a computer and write up a document. We became doctors to treat patients, to help people get well. And some people have more of a disposition towards writing things on the computer than others. People who are kinesthetic, especially surgeons, don't like to sit down and write things, I've found. So that makes having protocols updated by them very difficult. A third problem is poor internet access in certain patient care areas in our hospital. We don't know about your hospital, but probably Wi-Fi access is spotty. Some things you can have offline. Our Tansen clinical guidelines can be downloaded and used offline. UpToDate has an offline option, which also can be accessed without internet, but other resources may not be accessible. Another problem, not so common now, is that some people don't own a smartphone or don't have any portable device for accessing things at the bedside. Nowadays, this is rare. It seems like all the young doctors have their mobile phones with lots of memory space, but you may find it is in your situation. A fifth problem, and this is not just in Nepal, but worldwide, is just the pressure of the workload that we have to get through the encounter with the patient quickly to get to the next patient. This limits the time we have available for reviewing evidence-based information at the bedside during the encounter. We have to be disciplined, we have to be selective, but we should try to do it when there is questions. And the last challenge we face that I thought of was that sometimes subscriptions for UpToDate are time-consuming to get approval or sometimes not available. I had a personal experience with this month. My UpToDate subscription expired on November 1st. On October 1st, I was given a reminder and I wrote to the Global Health Foundation to renew my subsidized subscription, which they approved in 2 weeks and said that UpToDate will renew it, but that may take up to 3 weeks. Just some final thoughts now on using evidence-based medicine. 2 Bible verses that are helpful to think about maybe. The first one is Proverbs 15:22. Without counsel, plans fail, but with many advisors, they succeed. And perhaps the lesson for us in evidence-based medicine is that we need to consult several sources, that we need many advisors. Even Tansen clinical guidelines, I am confident, is not 100% the answer. And whatever other sources you have, it's also good to look at several different sources and see if they have similar recommendations or similar evidence for the question you have. The other verse is James 1:5. If any of you lacks wisdom, let him ask God, who gives generously to all without reproach, and it will be given him. And I think the lesson from that is that evidence-based medicine is good and wonderful and has its benefits, but it does not replace praying for God to help us and trusting on him to guide us through patient care decisions that we have to make. These are my references, and you can also access these from the CMDA management people. And I do want to thank you all for listening in, and hopefully there'll be time for questions now.